Hello, now it's my turn to talk about practices in fluid management. I hope you're enjoying the conference so far. I have the awesome luxury of getting to work with some amazing people that you've already heard speak today. I'm grateful for that. As far as my disclosures, I am a medical science liaison with Baxter, and I also still work PRN as a clinical nurse specialist at Cookeville Regional Medical Center. I am an independent consultant, PRN, and as far as non-financial, I am a Sepsis Alliance Advisory Board member. I want to say that I've been a clinical nurse specialist for a very long time, and so as I talk through this talk, I just want to let you know that I've had some experience with developing protocols and nurse-driven processes, and sometimes it can be challenging. So just know that I'm right there with you. Hang in there, and hopefully I can give you some insights to things that have helped me in my journey. So we're going to get right to it. We're going to discuss how to implement a fluid management program. We're going to also talk and explore best practices for fluid management program. And we're also going to examine what a fluid management program might look like. So let's talk about steps to develop a fluid management program. And I think it's important to kind of talk about some foundations and maybe sometimes step outside of the nursing world to get some change models out there that can help us as we implement in the medical world. So I'm going to talk in regards to Kotter's 8-step change model. And this is very much available online, as well as you can see my references there, but it's called the big opportunity. And when we think about changing processes in an institution, there are so many steps we need to think about. We need to think about creating that climate for change, creating urgency, creating a coalition, develop a vision and a strategy, and then engage and enable the whole organization, right? Communicate that vision, empower action, get quick wins, and then implement and sustain that change. And sometimes that can be the hardest, sustaining, right? But leverage wins to drive change and really embed this into your culture so that change can continue and sustain. I think it's also important to think about some leadership and management when we're talking about this change process. And Cotter also mentions that in order to capitalize on windows of opportunity, leadership must be paramount. And it's not just from one executive, it needs to be about vision, about action, about innovation and celebration, as well as an essential managerial processes. Also, select few and diverse many. More people need to be able to make change happen, right? Not just carry out someone else's directives, but done right, this can uncover leaders at all levels. So in your organization, maybe you never even realized the leader potential that some of the team members had. So hopefully this will help with that as well. And then your head versus your heart. Most people aren't inspired by logic alone, right? But rather the fundamental desire to contribute to a larger case. If you can give greater meaning and purpose to your effort, extraordinary results are possible. And I really like that. I think it's important for us to share our heart, to see how this will impact patients, how it will impact, it can make a difference. And then I think our heart gets more involved, right? Also, the have to versus the want to. Those who feel included in a meaningful opportunity will help create that change in addition to their normal responsibilities. Existing team members can provide that energy, but we have to invite them, right? It can't be exclusive. I think a great quick read for any of your team would be Our Iceberg is Melting, and this is by John Cotter. And really it explains how team together, TEAM, is more productive. I like that statement, T for and team together each achieve more. and taking those essential steps to pull a team together to guide the needed change. And also then as you read this short story, you can really see the benefits of having a team with different perspectives, right? It can really help build that team. I also wanted to bring in some, even though it's a little different than what we're covering, this is very similar, and it's by one of our leaders in fluid management, Dr. Malbrain, and also his team that he worked with to create this article. And it was just released in 2023. And I thought it was similar enough to bring this into this conversation today. But it talks about strategies to achieve institutional best practices in fluid stewardship. And I think fluid stewardship is part of that. It may be a subgroup of what we're talking about, but it also helps just us to see what's out there in the literature. And these this particular article talks about identifying clinical leads and then getting that agreement from relevant hospital departments to where you can work together, right? Obtaining support from management, agreeing on the choices of standardized fluids in the institution, and finalize your local guidance, as well as educating our prescribers, giving education then to nursing staff, establishing institutional policies for the use on pumps or other infusion systems, reviewing prescription and monitoring documentation, and then communicating clearly local guidance, and then implementing local guidance, auditing prescription, re-educating relevant staff as appropriate. Also, when we think along these lines, let's look at strategies to engage clinical leads with the implementation of a fluid stewardship program. So you have to establish your fluid stewardship team, your core team, determination of the objectives for the baseline snapshot measurement. So what is it we're looking at before we get started? Baseline snapshot measurement on IV fluid issuing and consumption, analysis of key performance indicators, and then you benchmark with area hospitals to compare, and then knowledge surveys of doctors and nurses. I think this is great to know here, where are we at baseline with the knowledge, and then you can always resurvey later to see if that knowledge is better. Medical audit, that can be optional. Determination of the change objectives, and then identification of stimulators and blockers of change. Identification of target audiences, coordination by clinical pharmacists, and then feedback of these results of the baseline snapshot measurement. And then the last, increased awareness. So these are just some strategies to engage those clinical leads. And I think as we talk about this is going to help us with what we've determined to be some of the best steps to initiate a fluid management program. So I'm going to call this the Baxter steps to develop a fluid management program, or the MSL's steps to develop a fluid management program, as we've worked together as a team to try to determine what our 6 best steps would be for fluid management programs. So some of the steps are different than Dr. Malbrain's because we're looking at things a little differently, but I think it's good to look at the research and what's out there. The first is data reflection. I like this statement from Tom Peters. You can only improve what you measure, right? So if we don't know where we're at, how can we move forward? And if we're not evaluating once we move forward, how do we know if we're doing any better, right? It's really important. So when you think about how we're doing, how are we going to evaluate that? So maybe a good population to evaluate might be your sepsis patients, because they tend to get a fair amount of fluid. You could look at DRG codes 870, 871, 872. And if you have a group, I know at my hospital I'm still affiliated with, I would get nurses to help me with projects, because that would help them on their ladder of excellence to increase. They have the ability to do things to get more dollars, right, in their pocket. So kind of like a ladder for excellence. As far as fluid management, you could also pick the septic shock patients in that first 3 hours. I like looking at the sepsis CMS data and looking at that 3-hour bundle compliance. That may help you, because that data is should already be gathered, or they should be gathering that fairly consistently. And then the percentage of fluid received, you could look at that based on mortality rates. You could also look at your stroke volume guided care versus usual care to look at that change in your percentage of CRT, your days of intubated patients, length of stay for the ICU. So remember back to that study that of the FRESH study that has already been talked about. I think it's important for us to look at those with your stroke volume guided care patients versus your non-stroke volume guided care patients. And you should be able to see that your fluid balance should be different, as well as your renal replacement therapy should be less in that stroke volume guided care, as well as mechanical ventilation less in that stroke volume guided care, length of stay in the ICU less in the stroke volume guided care, and then hopefully an increase in discharge home in your stroke volume guided care patient subgroup. I think it's important when we think about discharge home, it's important that we think about quality of life, right? Not just the fact that, hey, yay, we saved them, but do they have quality? And that is so important. And hopefully if they're getting discharged home, more chance for quality. Also, another idea could be for your data reflection would be to take the last 400 patients from your CMS database for sepsis, compare the fluid compliant patients to the patients that fell out of compliance, assess the difference in mortality, length of stay, CRT rates, and readmission rates. That's another option for you. Now, the second step would be support. It is important, and just like we saw in the Malbrain and also in Cotter's explanation, it's important that we have support, right? So there needs to be foundational support where people in the institution feel that support and feel like they can move forward. So when I think of support, I think of the C-suite, your CMO, your CEO, your CNO, your CFO, all of the C-suite. Are they aware of the potential consequences if there is no fluid management program? I know in the past when I have felt passionate about something and whenever we didn't have a certain program, I would take data and literature to the C-suite to make sure they were aware of our lack of whatever it was that we needed, to educate them, to bring the literature, right? So that they're aware of how important this is. And then having encouragement of a fluid management protocol. So your C-suite really needs to be encouraging of that. And then your directors, your CNSs, your educators, are these protocols, or excuse me, are there protocols to allow for nurses to assess non-invasive measurements and report those to the providers? And when I say providers, I'm talking about physicians, nurse practitioners, physician assistants, those who can write orders. And then from the standpoint of providers, are the providers open to this feedback and willing to act on it? It's one thing if we have a protocol with nursing, but if the providers are not on board, that can cause friction. And we never want that. We want our team to be cohesive. We want us all to be on the same page, right? And then we want there to be a safe environment. Do the nurses feel empowered by this support so that they will advocate for their patients and assess fluid status? Is this well supported in a policy to where nurses can feel that support? So it's important that whether it's in protocolization of order sets, whether it's standing orders, or whether it's in a policy to where it's been approved at the highest levels of the hospital so that nurses do feel that support to move forward. A main takeaway, I think, for support is that this is a team sport, right? We win as a team, we lose as a team. Everyone has a role in supporting a hospital best practice initiative. So if we work there, we all have a role in this. The third step is development. What needs to be developed? Well, quite a bit needs to be developed, let me tell you. You need to have nurse-driven protocols for fluid responsiveness. This would give the ability of the nurses to be able to assess. We could do a passive leg raise if the patient is fluid responsive or not to assess that. And then this needs to be supported by the physicians, the APNs, the PAs, and the bedside nurses to be successful. Now, there also should be some orders for the provider so that they can easily initiate this as an order. So an order built for provider entry. Sometimes, and especially now, we've got a lot of novice nurses. In case they don't feel as confident to take that initiative, the doctor could then, or the provider could then initiate an order. The providers, also, the question would be, are the providers open to this feedback and willing to act on it? So I think it's important that, like I said, we're all on the same page. And then there needs to be a safe environment. Do nurses feel empowered by the support so they will advocate for their patients and assess fluid status? So here are some of those samples to hopefully help you as you're developing your nurse, not just your nurse, but your hospital fluid management protocol. Here's an example of what a nurse-driven protocol, the verbiage, could look like. If a patient is hemodynamically unstable, so you need to define that for your hospital. I've got here a map of less than 65 on a vasopressor or an inotrope, or if clarification of fluid status is needed, may connect non-invasive hemodynamic monitoring and do a passive leg raise PRN. If unable to do a PLR, notify the provider to see if he or she would like a fluid challenge. And I know at the institution I work at, that is very similar to how it's worded. And the providers, we did not get the ability to give a fluid bolus, but we were able to do a passive leg raise. And there's nothing wrong with that. That's great. So start with that. And then if the providers feel confident for you to give a fluid bolus, some institutions will go ahead and implement that. An example computer order would be connect non-invasive hemodynamic monitoring to the patient and do a passive leg raise and document percentage of change in stroke volume or stroke volume index and notify the provider with the results. And you also want to make sure there's a place in your documentation to note that. We've got a spot at the hospital I'm still affiliated with. It's a dynamic assessment where we put in the percentage of change in stroke volume if they have had a fluid bolus or if they had a passive leg raise. Next is education. So who or what needs to be educated? Well, the providers need to be educated just like the nurses do, right? So we need to know the expectation. The providers need to know the expectation of the nurses to communicate to them and implement the protocol without even being asked, right? It's a nurse-driven protocol. So they bring that information to the providers. The nurses need to know the expectation of that. To implement the protocol without being asked and to give results to the provider. So an example would be if their patient becomes hypotensive or hypoperfused in some way, shape, or form, do that assessment, do a passive leg raise if they're able to, and then bring that information to the provider. An example would be, hey, doctor, my patient just became hypotensive. I quickly did a passive leg raise. They had a 20% increase in stroke volume. Would you like me to give them a fluid bolus? And they may say yes, or they may say, let me come see that patient. It's going to be specific to what the provider wants to order and their assessment as well. I don't want to negate the importance of a good physical assessment on these patients as well. All right, so then the CNS and the educators as they're educating, need to start with the why. It's important that we understand the why. And just like our head with our heart, if we are just being told to do something, sometimes we want to push back, right? But if we understand why and the importance of that, so we need to look at that data reflection. We need to look at patient outcomes so we understand why we're doing what we're doing. And then we need to have unit champions who will be the experts on the unit, right? Who can easily help the other nurses do the passive leg raise. And then we need to educate our rapid response teams because we know that the ICU beds are at a premium, right? We don't always have room for patients. So if we can evaluate them on a floor and then determine that they're fluid responsive and we can increase their blood pressure with some fluid and they can stay on a step down floor, that's great, right? And then also our resource nurses. Hospitals are hiring resource nurses these days, people to help maybe the younger, more novice nurses as they are have some knowledge-based deficits, right? So we can have them help educate as well. Also, how can this be done? How can this education be done? One of the things I took on at my hospital when I was there full time was I got discouraged because a lot of the physicians or providers, I wasn't sure they were ever being told of the protocols that we had in place. So I felt like it was important that they know that. So we had worked hard on these protocols, so we want to make sure that everyone is aware. So I would start meeting with all the new hires of the physicians, whether that was contractual, the locums. I tried to meet with all of them to go over these protocols. And then it is so important that we don't forget our contractual providers as well. Class education can be done for technology. I've done classes for providers in order to give them a safe space for explaining the technology. And then I think it just betters that nurse to physician collaboration, right? We can work together. And I taught quite a few hemodynamic classes for the providers. And then if the technology is not understood, then we need to follow up, right? And do some of that. As far as the nurses, the CNS and the educators need to educate the nurses. Do not forget the contractual nurses once again as well. Those contractual people that come into our institution, it's still our responsibility to educate them and tell them what our expectations are. We don't want to have poor outcomes because we haven't educated them on the protocols that we're doing at our hospital. Orientation is very important for all nurses, and we can also build on that orientation by having health streams that cover the information first, and then they could come into a classroom situation. Also educating our preceptors, making sure that they have hands-on help after go live, also making sure the preceptors feel very comfortable with this information. And number 5 is accountability. Having provider accountability, interactions, and support for the program is so important. Nurses, as they teach new orientees and they support the hospital initiatives, we need to make sure they're held accountable. And then the C-suite, they need to make sure that resource allocation is appropriate. Resource allocation is there, appropriate technology that can determine stroke volume percentage of change in real time, and then also the C-suite to hold nursing and providers accountable to the hospital-driven initiatives. The last would be treatment options or choice. So we want to make sure we have the right monitoring devices, the right solution, the right patient at the right time, right? So right IV fluids, appropriate IV solutions and types available. Remember, as we talked about, a lot of the information about balanced solutions, so making sure we have balanced solutions available, appropriate options based on patient situations, as well as the right monitor. Do you have a non-invasive stroke volume or stroke volume index monitoring to assess fluid responsiveness? And then having those safe and smart IV pumps so that hopefully less errors are made. Now, quickly, I just want to talk about some barriers that can occur when we're rolling out an initiative like this. First of all, documentation. Remember, if it did not happen if it's not documented, right? So we want to make sure we support our nurses with the appropriate documentation sections in the electronic medical record. And sometimes this can take quite a bit of time, but what I found at my community hospital, my IT department, was able to change things very quickly based on our needs. Also remember, barriers can be provider or even nursing resistance. So we really need to come around and support the providers and the nursing to make sure they understand what they're looking at, to make sure they understand the technology and understand the research and the science behind it. Sometimes I find that lack of accountability can be frustrating, so we need to remember C-suite has a very important role in accountability. Nursing directors have a very important role in accountability, CNSs as well as the educators. So we want to make sure we hold people accountable to the processes that are at our hospitals or that are supposed to be rolled out. And then we know that continual turnover of nurses makes it challenging for education. I don't know if that's going to change anytime in the near future. So having a program in place to where all of your nurses get educated to where they get the information they need. In the words of Mark Twain, you're never wrong for doing the right thing. But I would add that doing the right thing often takes great courage and integrity, and that is so true. Sometimes I find that the right thing to do seems like the harder thing to do sometimes. But I think if we can remember the patient is at the core of this, and we all want best patient outcomes. Here is my reference list. There is some great information on this reference list. I encourage you to print these articles out and review this information. So at this time, we will take any questions that you have.